Welcome to this explainer where we're going to break down the absolute clinical essentials of the liver. If you're prepping for medical exams, this is definitely the high-yield review you've been looking for.
So, what's our roadmap for this explainer? We're going to start with the basics, the real foundational science. Think anatomy, blood supply, and those all-important liver function tests. Then, we'll jump straight into the clinical picture, the stuff you'll actually see on the wards. We've set it up this way to make sure these key concepts really stick, not just for your exams, but for your practice too.
All right, let's kick things off with part one. Look, before we can even begin to understand what goes wrong with the liver, we absolutely have to master the fundamentals of this incredible organ. We're talking everything from its super unique blood supply to how we actually measure its function. This is the bedrock of your entire clinical understanding.
So let's think about this, because this concept is absolutely crucial. The liver is, well, it's special. Unlike pretty much every other organ, it gets a whopping 75% of its blood from the portal vein. And what's in that blood? It's nutrient-rich, but deoxygenated, coming straight from the gut. The other 25%, that comes from the hepatic artery, and that's where the oxygen is. This whole dual system is the absolute key to understanding the liver's massive role in metabolism and detoxification.
Okay, so we've got the basic plumbing down. Now, how do we check the engine? Well, that's where liver function tests, or LFTs, come in. Think of them as our window into the health of the liver. In this next bit, we're going to decode what these super common lab values are actually telling us.
Now, this is something that's really interesting, and honestly, it trips a lot of people up. High AST and ALT levels, they don't actually measure liver function. Nope, they measure liver injury. It's like a distress signal from the liver cells themselves. When the cells get damaged, these enzymes leak out. And a little pro tip, AST is more specific to the liver, whereas AST can pop up from muscle and red blood cells too.
It's all about the pattern here. That's the key takeaway. It is not enough to just see a high number on a lab report. You have to compare them. So if you see a massive spike in ALT and AST, that's screaming hepatocellular pattern, damage to the liver cells themselves. But if you see a big rise in ALP instead, now you should be thinking about a problem with bile flow. That's a cholestatic or obstructive pattern. It's like being a detective.
And this right here, this is a critical clinical pearl. If AST and ALT tell you about ongoing injury, then what tells you how well the liver is actually working? It's the albumin levels and the prothrombin time, or PT/INR. See, the liver is a factory. It makes albumin, it makes clotting factors. So when your albumin is low or your PT is prolonged, that's a huge red flag. It tells you the factory is failing, and that often means chronic, severe dysfunction.
Okay, we have officially built our foundation. Now, this brings us to part two, where we get to apply all that knowledge to a classic clinical scenario. We're going to start with a patient, just like you would on the wards, yellow eyes, swollen belly, and work backwards to figure out what's going on, linking those lab findings directly to what we're seeing at the bedside.
When you get right down to it, it all comes down to a number. See, the portal vein is supposed to be a low-pressure system, right? We're talking pressures between 7 to 10 millimeters of mercury. But once that pressure creeps up and stays above that critical threshold of 12, the system just can't handle it anymore. It starts to fail, and the blood is forced to find other, often way more dangerous routes to escape. And this analogy is just perfect for understanding the core problem. Just imagine the liver is a major highway for all that portal blood. Now, what happens when there's a huge blockage on the highway? Well, all that traffic gets rerouted onto these tiny country roads that were never meant to handle that kind of volume. These detours, we call them shunts, from the portal system to the systemic system, are exactly what cause all those classic signs we see in patients.
So let's break down the three most important detours you absolutely need to know. First up, at the lower esophagus. The backup of blood creates these things called esophageal varices, and these are incredibly dangerous because they can rupture and cause life-threatening bleeding. Second, around the belly button, you get that classic sign, capomedusa. And finally, down at the rectum, all that pressure can lead to hemorrhoids. Just remember, every single one of these signs is a direct result of that traffic jam, blood being forced to reroute from the high-pressure portal system.
And speaking of unforgettable signs, here it is. The name Caput Medusa literally means head of Medusa, from the myth with the snakes for hair. It's such a dramatic, direct visualization of what's happening inside, severe portal hypertension playing out right there on the patient's abdomen.
Okay, so we understand the consequences of all this high pressure. We see the varices, we see the caput medusae, but that brings us to the next big question, right? What is causing the roadblock on that highway in the first place? Well, in most cases, the answer is a disease process we're about to dive into right now, cirrhosis.
So how does cirrhosis do this? It's really a structural problem. In cirrhosis, you have this long-term chronic injury to the liver. This leads to widespread fibrosis, that's scarring. And the liver tries to heal by forming these regenerative nodules. But this whole process just messes up the liver's normal architecture. The scarred, dense tissue literally squeezes down on the tiny blood vessels inside the liver, which cranks up the resistance to blood flow. It's like building a dam, and the pressure just has to build up behind it.
Now, even though cirrhosis is a huge cause of what we call medical jaundice, it's so important to remember that not all jaundice comes from sick liver cells. A huge challenge in the clinic is telling that apart from surgical jaundice, which is caused by a physical blockage outside the liver. This table gives us some really high-yield clues. For example, that intense, severe itching, we call it pruritus, is a big tip-off for a surgical obstructive cause because of all the bile salts building up.
All right, now it's time to get into some of those classic name signs. You know, the pearls that always seem to pop up on exams and are absolutely essential for making you look sharp at the bedside.
This is such a fantastic piece of clinical reasoning. Let's walk through the logic, because it's just brilliant. If you have a gallstone, it usually causes chronic inflammation. That makes the gallbladder all scarred up, shrunken, and you can't feel it. But if you have a tumor that's slowly blocking the bile duct, a healthy gallbladder will just passively fill up with bile and distend, getting bigger and bigger. So it becomes palpable. But because there's no acute inflammation, it's not tender. See? So cool.
And here's another classic move for your physical exam. Picture this. You're pressing down in the right upper quadrant, right where the gallbladder is. If it's inflamed, that's already going to be tender. Now, you ask the patient to take a deep breath in. As they do, their diaphragm pushes the liver and that angry gallbladder right down onto your waiting fingers. Bam! They get a sharp stab of pain and immediately stop breathing in. That, my friends, is a positive Murphy sign.
Wow, okay, we have covered a lot of ground. We've gone from the foundational stuff like LFTs and blood supply, all the way through to portal hypertension, cirrhosis, and those key clinical signs. So let's wrap this up and consolidate everything in our final section, a rapid revision to really lock this knowledge in for your exams.
All right, you ready? Here's your rapid-fire summary. You need to burn these 6 facts into your brain. 1. The liver's dual blood supply is about 75% portal vein, 25% hepatic artery. 2. Albumin and PT/INR are the true test of the liver's synthetic function. 3. Portal hypertension kicks in at a pressure over 12 millimeters of mercury. 4. Splenomegaly is your #1 bedside sign for it. 5. The most common cause of all this mess is cirrhosis. And 6. Esophageal varices are a shunt between the left gastric and azygos veins. Got it? Good.
All right, first test question. A patient's labs come back. They've got a super high ALT and AST, but their ALP is totally normal. What does that pattern suggest? I'll give you a second. Okay, if you picked B, hepatocellular injury, you are absolutely correct. Remember, AST and ALT are your markers for liver cell damage.
Question number 2. According to Courvoisier's law, what's the most likely underlying cause for that palpable non-tender gallbladder? The answer is C, neoplastic obstruction. Just remember that logic. A slow-growing tumor lets a healthy gallbladder stretch out, making it easy to feel but not painful.
And for our final question, what is that cardinal #1 bedside finding for portal hypertension? We really hammered this one home earlier. The single most reliable clinical sign is C, splenomegaly. It's all because of that backflow of pressure from the portal vein straight into the spleen.
And that's a wrap on our deep dive into the clinical essentials of the liver, all the way from the basic science to the bedside. I really hope this helps you absolutely crush it on your exams and on your rounds. Hey, do us a favor and let us know in the comments what tricky topic you want us to break down next.